My name is Stu Tepper, and I'm going to talk a little bit about the new medications for headache, for migraine, which I think are extremely exciting. I'm a professor of neurology at the Geisel School of Medicine in Dartmouth, and I've been a headache specialist since the Ronald Reagan administration. So this is really, really exciting time for me. This is one of the most exciting times in my professional career. I'm so excited for patients. So I want to start by talking about what CGRP is. CGRP stands for calcitonin gene-related peptide, and it is a protein that is released around the brain. And in most migraine patients, when CGRP is released, it causes the migraine. And it does that by causing intense inflammation, and blood vessels get big, and this occurs in the coverings of the brain, in the meninges. And so if you give CGRP by an intravenous method to a person with migraine, usually most of them by 4 hours will get a migraine. That's the basis of all the new treatments, and we've gotten a ton of questions for the Facebook Live tonight. And so I'm just going to go through as many of them as I can. Probably go a little bit longer than a half an hour. And if there are more questions, then we can always schedule another one if you think this is helpful. Let me begin by answering the question of how do the new drugs work and what's their relationship to CGRP. The idea came that if CGRP caused migraine, if we could do something to stop CGRP, we could probably stop migraine. And so the first drugs that were created to stop CGRP were what are referred to as small molecule GPANTs. The name of the group was GPANTs. And GPANTs don't actually take on CGRP, but they block the receptor or the docking station that CGRP connects to around the brain. And GPANTs turned out to be effective anti-migraine treatment for as-needed treatment, for acute treatment. They were similar to triptans. The problem with the GPANTs were that some of them were poisonous to the liver. But there are 4 GPANTs now that are being studied. 2 of them are being studied for acute as-needed treatment for migraine, and 2 of them are being studied on a daily basis to block the CGRP receptor to try to prevent migraine. We don't know if that's going to work, and we have to make sure that they're not poisonous to the liver. And the first GPANTs should be out in 2020. But the problem, as you can tell with the GPANTs, was this concern about the liver. 4 companies decided that a way around this would be to create antibodies against either CGRP or against the receptor that CGRP binds to. These antibodies are called monoclonal antibodies, and they're very big molecules. They do not cross into the brain. They work outside the brain. And they don't go through the liver, so there's not a liver problem with them. But because they're such big molecules, they actually have to be injected in order to get into the system. But they work preventively to prevent migraine. And there are, as I say, there are 4 of them. And one of them is a monoclonal antibody against the CGRP receptor. That's the one that got approved last week. And 3 of them are monoclonal antibodies against the CGRP protein or peptide itself. One of those is likely to come out later this year, at least one of them, and probably 2 will come out next year. So these are the new drugs, the monoclonal antibodies, one of which is now available and 3 of which are coming over the next year and a half, we think. Now, they are very different than any kind of preventive medicines we've ever had for migraine. So people have asked online, when would you begin to see results if you were somebody taking them, and what potential side effects are there? And I'll deal with the side effect part first. They are extremely well tolerated. They don't seem to have significant side effects other than for those that get injected, there can be some pain at the injection site. But otherwise, the side effects are very minimal. These are very well tolerated. And the first 3 of them, including the one that got approved last week, are injected by you, the patient, once a month, and with a subcutaneous auto-injector. What makes them different, besides the fact that they're very well tolerated, is that they work extremely fast. For our usual preventive medicines, we usually work up to the correct dose, and then we wait 3 months and see whether they're effective. If one is taking onabotulinum toxin A, the brand name of which is Botox, we usually do 3 cycles of 31 injections, separated each cycle by 12 weeks, and then wait at least another month or 2 after the 3rd cycle. So it can take 7 or 8 months to see whether Botox is working. And I don't want to use the brand name, so I am going to call it onabotulinum toxin A. And with these new drugs, with the monoclonal antibodies, most patients who are going to respond will see significant clinical benefit within a month. And they are fast. They are so fast that the companies which are making the first one, which was approved last week, which is called Erenumab, the brand name of which is Aimovig, the company that is making that particular monoclonal antibody is offering for patients with commercial insurance the first 2 doses for free, because they figure within 2 months everybody's going to know, or almost everybody's going to know, whether it's working, and that if it's working, then that would be evidence for the insurance companies to pay for the drug after the first 2 months. There are exceptions to who is going to be able to get those first free 2 doses and get insurance coverage for the first monoclonal antibody. So far, we don't believe that there's coverage with Medicare or with Medicaid or with federal insurance. And the state of Massachusetts, for whatever reason, prohibits the first 2 doses for free. But people with commercial insurance will probably be subject to the same requirements that are currently in place for onabotulinum toxin A. And that means that people with migraine will have to have had a lack of success with an antidepressant, an anti-epilepsy drug, and an anti-blood pressure drug, or 2 out of those 3. And if those have not been successful in treating the migraine, and there is commercial insurance, then probably the patient would be a candidate for payer to pay for the new monoclonal antibody. And that's a lot of people. The monoclonal antibodies have all been studied in episodic migraine, meaning headache days less than 15 days per month, and in chronic migraine, that is headache days 15 or more days per month. They work in both, and they're approved by the FDA for both. That's a pretty exciting turn of events as well, because right now we don't really have any preventive treatment that is approved for both episodic and chronic migraine, any medication treatment. Another difference with these new drugs is that they are designer drugs for migraine. As I don't need to tell everybody who's listening, our current preventive drugs were invented for something else and then turned out to have modest benefit for migraine prevention, but they weren't designed for migraine prevention. These monoclonal antibodies are designed to target CGRP or its receptor, and because they're so narrowly targeted, they don't seem to take a lot of collateral prisoners. They don't cause other side effects, and they don't go through the liver, so they don't seem to have that problem. Now, there are multiple questions about that I want to try to get to, and as many as I can. One person wrote in, is there any way to receive these treatments besides by injection? And the answer is, for the monoclonal antibodies, they will not be oral. As I said, the first 3 are going to be by patient self-injection with a subcutaneous auto-injector at home. Two of them will always be monthly, and one of them will be either monthly or quarterly self-injection. The fourth one is going to be available by an infusion, an intravenous infusion, which will be given every quarter. But the patient would have to come into the doctor's office to receive the fourth one, which we would expect at the end of next year or in 2020. Are there differences between them? Well, the first one, the one that just got approved, Erenumab, is the only monoclonal antibody that is against the CGRP receptor. The other three are against the CGRP protein. What we don't know is if somebody doesn't respond to the first one, the antibody against the receptor, would they respond to one against the protein? And we don't know whether somebody who didn't respond to subcutaneous injections might respond rather to an intravenous infusion when that one becomes available. So there's a lot of questions that we don't know, and we look forward to being able to get these medications for our patients and have patients try them out and see how they do. Next question that came in was, how much relief can patients expect to receive? And I think the best way to look at that, so that we don't make the same mistake we made with onibotulinum toxin A, is to look at what is the drop from baseline of the number of migraine days that people get with these new drugs. And for patients with episodic migraine, that is less than 15 headache days per month, the new drugs drop the number of migraine days per month by 2 to 4 days, generally around 4 days. If you multiply 4 days per month of no migraine times 12 months, then you have 48 days of no migraine per year that a person would previously have had migraine. So about a month and a half of no migraine per year compared to no treatment. And for the chronic migraine patients, that is headache 15 or more days per month, these drugs drop the number of migraine days by 6 to 8 days per month. Of course, people with chronic migraine have more headache days per month to begin with. But 6 to 8 days per month multiplied by 12 means that people could be expected to have 2.5 months of no migraine, even 3 months of no migraine per year that they previously had migraine. And that's a pretty dramatic drop in the number of days of no migraine in a year and per month. That's why we're very, very excited. Do we think there's a difference between each of these? They all seem to be similar in kicking in within a month. They all seem to be similar in the magnitude of the drop of the number of headache days. They all seem to be similar in the tolerability. It's possible that one might be better for one patient versus another, or that infusion might be faster than subcutaneous. We just don't know. And right now we only have the one subcutaneous Erenumab given once a month. Are there any reasons, another question, for a pre-existing health condition or another medicine that would prevent somebody from receiving the treatments? Not that we know of. Erenumab, the one that was approved, has been studied in patients with angina and heart disease. And in that study, there was no impact on the angina in patients with pretty frequent angina. Erenumab has also been studied in people with risk factors for coronary disease and vascular disease, and didn't appear to be a problem with that. And there doesn't seem to be any drug-drug interactions that we know of with these monoclonal antibodies and other treatments, and people would still be able to use their acute treatments when a migraine would break through, because for most people, these aren't going to completely eliminate the migraine. They're going to help with frequency, severity, and duration. The next question was, should people living with migraine approach this treatment option with caution, or is it a viable option for most? I think that the payers are going to limit who gets these drugs to people who have had a lack of success with 2 or 3 of the conventional preventive medications. Having said that, the one that was approved, erenumab, was studied in a particular prospective study, meaning they started at the beginning and they gathered people who had already had 2 to 4 preventive medication failures, and I mean complete failures. So these were people that had taken antidepressants, anti-epilepsy drugs, anti-blood pressure drugs that were effective for migraine prevention, and they had not worked at all. And then these patients were given the monoclonal antibody, and it still seemed to work. Others of the other monoclonal antibodies are also studying people who have had a lack of success with their previous treatments, and it looks very good in terms of likelihood of success, even though people have had a lack of success with previous treatments. I don't think we would give everybody with migraine this treatment option. I think that we're going to be limited by our insurance and by cost, but I think that the more disabled people, the people that have tried the hardest and done the most and have had a lack of success, they are the candidates for whom these medicines should be made accessible. Are they treatments expected to work for most migraine cases or for only specific types of migraine or symptoms? Well, once again, I have only good news on this. These monoclonal antibodies were tested for migraine with aura, migraine without aura, episodic migraine, chronic migraine, medication overuse headache, and they worked equally well in every single one of those groups. So if you are somebody who's very disabled by migraine and has had a lack of success with prevention and currently has commercial insurance, these are very reasonable. This would be a very reasonable option. And we don't know how long it'll be before Medicare and Medicaid and federal insurance comes on board to cover them, but we hope sooner rather than later. Next question was, are the treatments meant to be used in addition to current migraine treatment plans or completely replace a treatment regimen? Well, what I'm doing is if the patient is on conventional oral prevention without great success, I would give the patient a couple of months of the monoclonal antibody, and if it has a pretty dramatic effect, then I would wean people off of their previous treatment. For onabotulinum toxin A injections, we kind of made a decision that we would wait 3.5 months after the last set of injections so that we could clearly see whether the new treatment would work. And we don't have any plans to combine onabotulinum toxin treatment with the newer treatments. And of course, onabotulinum toxin is only approved for chronic migraine anyway. The next question is something I hear quite a bit is, these treatments have been said only to alleviate a few headaches a month. Would it be worth it for me to try? I should warn you that people who are Debbie Downers about this, people who are negative about these drugs, what they do is they look at the number of headache days that drop per month with the treatment and the number of headache days that drop with placebo, and they subtract the placebo from the active treatment response. And that comes out, for example, in episodic migraine to 1 or 2 days per month instead of 4 days per month, or 6 to 8 days per month in chronic migraine. But people do not receive placebo in real life. And what counts is the drop from the baseline. And we made the same mistake when onabotulinum toxin A was approved by the FDA for prevention of chronic migraine. And it is a gross underestimate to think that these are only going to alleviate a few days per month. I think they're likely to do much more than that. Plus, if they work like onabotulinum toxin A, and I think they'll work at least that well, they're going to reduce not just the frequency of migraine days per month, but the intensity and the duration of the attacks. And maybe they'll help with the acute treatments as well, because when people get their foot off the accelerator, the brake works better. The next question was, does a treatment plan mean a shot every month indefinitely? Or is there a schedule with a definitive endpoint? And the answer is, we don't know. What we will do probably is treat with, have people treat themselves at home once a month for a year, and then we'll see where we stand. Some of them, as I said, there's one of them that is going to be approved probably for quarterly auto injection at home. We could switch people who want to do less injections to that. We could switch people to intravenous. But if the headaches come right back once they go off the monoclonal antibodies, then we'll know that we need to maintain the treatment. Monoclonal antibodies do remain in the system for 2, 3, sometimes even 4 months. So even with the discontinuation of the treatment, there may be a prolonged benefit before they wear off. Again, we really don't know. The next question is, would these treatments be safe for women who are pregnant or breastfeeding? Well, I certainly don't want my patients who go on these to get pregnant or to use them during breastfeeding. I worry about the medication being on board for so long, for months at a time, and so I am going to ask my patients to have very good birth control before we initiate the treatment. We don't know about safety, but I don't want one of my patients to be the one to try to find out. The next question is how to get access to the treatments. And as I said, if you have commercial insurance, then what you can, and you've had a lack of success with an antidepressant, an anti-epilepsy drug, and an anti-blood pressure drug, that's probably what needs to be documented by your healthcare provider, and then they can write a prescription, and that would initiate the treatment for commercial insurance. That's what I think at this point. I don't have any idea about Medicare, Medicaid, federal. And are most insurance plans likely to cover the treatment? I think so. The cost of the one that was approved last week is a little bit, just a tiny bit more than the cost of 2 onabotulinum toxin A vials for 4 cycles in a year. And that doesn't take into account the doctor fee or the room fee or the hospital fee for doing the onabotulinum injections. So my guess is that the one that was approved last week will be actually less expensive than onabotulinum toxin A, and that therefore most insurance plans are likely to cover it. But remember that if you have commercial insurance, you can find out if it's going to work for you by trying it for the first 2 months without cost. And at that time, your healthcare provider could submit access. My guess is that the other 3 are going to have similar plans to help people get these medications. And it's too early to tell, only about a week, so we don't know how quickly the insurance plans are stepping to the plate, but we certainly have a lot of patients who want to access these medications as quickly as possible. I don't know what's going to happen with Medicaid. As I said, with onabotulinum toxin A, it was approved by the FDA in 2010. I believe that Medicare started paying for it in 2012, and then Medicaid didn't really start paying for it until 2015, 5 years later, with all of the requirements for prior authorization. So I think it could be a slow boat in terms of getting our federal healthcare plans on board. And I think if every single one of you contacts Medicare and Medicaid to demand the medications as quickly as possible, that can't hurt. That's got to be helpful. One question is, what will the out-of-pocket cost be? And I don't have any idea. I think it really depends on the payer and whether you have a tiered pay system or a percentage pay system, or whether the company that makes a particular monoclonal antibody is willing to defray the cost of the copay. And Massachusetts does not allow that, but every other state does. So it's possible that with special programs, the out-of-pocket cost could be very significantly reduced. And I don't have any information on what those plans are with respect to these companies yet, because the treatments have only been available for a week. Is the treatment available only in the United States? The answer to that is yes. We are the first country to get the first anti-CGRP receptor monoclonal antibody, and we are the only country that has arenumab available. And then just to give you the names of what's coming, this fall or early winter, we expect the second one to come, which is called galcanezumab. There's a third one called fremanezumab, which could come either later this year or next year. And then the intravenous one is called eptinezumab. And the MAB at the end stands for monoclonal antibody. So I'd like to summarize where I think we stand and why I'm so excited for my patients and why I think this is the most important change in headache treatment since sumatriptan was approved in 1993. We've never had preventive medication designed for migraine in our lifetime. These are designer medications. We've never had preventive medicines that are very, very well tolerated. All of our current preventive medicines have side effects that really often prevent people from using them. We've never had preventive medicines that kick in and give significant clinical benefit within a month. So if you add all of that up, this really seems like a watershed moment. And these medications are for both episodic migraine and chronic migraine, for migraine with aura and migraine without aura, for medication overuse and for no medication overuse. And I can't wait for my patients to be able to access them. We know they work in patients that have had a lack of success with 2, 3, and 4 previous preventive medications. And you can see why I'm so excited. A reporter was asking me last week about this, and I said, I really feel like the ground is shaking under our feet. I feel like this is a time when prevention and the way we treat migraine is about to change for the better. And I'm extremely happy for patients with migraine and people with migraine across the country at this time. I'll say thank you now. And as I said, I'm available if everybody wants to do a second Facebook Live. I hope I was able to answer most of the questions that you had. And at this point, I'm going to sign out. Thank you.